Welcome once again to 10 Minutes with Harry. We are continuing with our series on the interpretation of the normal pacemaker electrocardiograph. And today, number 7, I'd like to talk on rate adaptive pacing. Let's look at this electrocardiograph. It's V1 and it's a tall R wave and a broad QRS. The rate is approximately 42 beats per minute, and clearly it is atrial fibrillation with a slow ventricular response. As well as this, it's very regular, and there is a right bundle branch block configuration. This is clearly a high degree AV block, and we can comfortably call this atrial fibrillation with complete heart block. What about this electrocardiograph? Here we can see a sinus bradycardia. As well as this, we can see sinoatrial block. Then there is sinus arrest, and there are junctional escape beats. This completes a syndrome which is called the sick sinus syndrome. Now, both of these ECGs clearly require pacing. But with established bradycardias like this, both VVI and DDD pacing have a flat rate profile over 24 hours. This is a Holter monitor rate profile, and you can see that over the 24 hours, the rate is predominantly 60 beats per minute, although it does get up to 75 to 80 beats at times, with exertion, obviously. Putting a pacemaker in such patients, therefore, leaves the rate at whatever you set it, at 60 or 70 beats per minute. And there is no change, therefore, with a physiologic response to exercise. So we need to increase the pacing rate in response to physiologic demand. This is called rate adaptive pacing. The rationale is that we need to develop a sensor which accurately emulates changes in cardiac output in a linear fashion in response to physical and emotional stimuli and incorporate this into the pacemaker pulse generator. The ideal sensor should also measure sympathetic tone or circulating catecholamine levels. The ideal sensor is small, solid state, and reliable. It's low cost, compatible with any lead. It needs to lie outside the lead in a pulse generator which is hermetically sealed and should be non-toxic, non-thrombogenic, non-irritating, and non-carcinogenic. It needs to have low power consumption. So during the early 1990s, a whole lot of sensors were developed for rate adaptive pacing. The ones that became most popular were those that used a standard lead. And you can see a list here. There was also an attempt to build rate adaptive pacing systems requiring special leads: pH, temperature, oxygen, and pressures and volumes. These were pushed very strongly by the physiologists, but really never became popular. So today we have activity, or the accelerometer, being by far the most common. We also have minute ventilation and closed loop stimulation. And as of the special leads, very recently, temperature has been incorporated, but not into the lead, but rather into a pulse generator, which is a leadless pulse generator implanted in the right ventricle. Some of these rate adaptive pacing sensors have characteristics on the leads which we will see. But let's have a look at an exercise test. Remember, we had this slow atrial fibrillation, and we put in a ventricular pacemaker, VVIR. At rest, the rate is 75. With exercise, you can see it increases to 94, and the peak exercise goes to about 115 beats per minute. This is a physiologic response to exertion and has been very, very successful. With the sick sinus syndrome, as we saw, at rest, we have atrial pacing and ventricular sensing. Then, with commencing of exercise, the rate goes to 70 beats per minute, which of course is atrial pacing and ventricular sensing. During the exercise, in this example, there is some ventricular pacing as well. And then at peak exercise, atrial pacing, ventricular sensing at 130 beats per minute, a highly physiologic response to exertion. The activity sensor, which I stated was the most commonly used and mainly today an accelerometer, as can be seen here, is a piezoelectric ceramic crystal bonded to the inside of the pulse generator can. With vibration, the piezoelectric crystals produce a minute amount of electricity which returns to the electronics within the pulse generator and is recognized and increases the pacing rate. Most of you will be familiar with the echocardiograph transducer. It too is a piezoelectric crystal, but the electricity is passed through that crystal when we are using it for echocardiographs and ultrasound, and then the vibration returns as ultrasound to the machine, and as a result of this, which is exactly the opposite, it too can be used, but now for opposite reasons to what we use in the activity sensor. What about the minute ventilation sensor? The rationale is that heart rate and minute ventilation correlate very closely. So we can use changes in minute ventilation to drive a pacemaker. The sensor measures transthoracic impedance. And these changes in transthoracic impedance occur as a result of changes in respiration, both in the tidal volume and respiratory rate, the product of which is minute ventilation. And how does transthoracic impedance work? Well, here we have the sensor, which is an electronic sensor, essentially built within the pulse generator can, and uses a bipolar lead. We can see then through the anode of the pacemaker lead 1 milliamp, 15 microsecond pulses every 46 milliseconds. So every 46 milliseconds, the small little squares on the ECG, there is an artifact which is of course subthreshold and of course does not pace the heart. Then these are measured, these impulses and the changes in transthoracic impedance is measured from the tip of the lead through, and you can see the green arrow to the pulse generator can. On the electrocardiograph, we can see these spikes. Again, these can be filtered out with some ECG machines, whereas in other ECG machines, they're very prominent. And they occur, as I said, every 46 milliseconds, which was the original design and may be different today in products that are available today. Here is a typical ECG showing the marked artifacts with minute ventilation sensor every 46 milliseconds. We can see in lead 1 that there is virtually no artifact. And this is lead 1, left arm and right arm. And this seems to have filtered out, and it's quite characteristic on these ECGs, not to see anything in lead 1. At the top of a tracing with the yellow highlight, you can see that the artifact has been documented every 46 milliseconds. Here are just 3 illustrations of different ECG patterns seen, and they are not consistent, and again sometimes the filters of the ECG machine wipe them out and you get them appearing and then disappearing, appearing and disappearing. And they give quite characteristic but different pictures. One of the disadvantages of the minute ventilation sensor is hyperventilation. This is a patient who was admitted to the emergency room with profound anxiety and hyperventilating. It was quite clear that she was hyperventilating at the time, and this ECG was obtained at the upper rate limit of 150 beats per minute, and you can see there's no pacemaker stimulus artifact seen there, nor are there any of the other artifacts seen. The patient was given a sedative, and 10 minutes later, the ECG rate had fallen to 90 beats per minute, and it was clearly the hyperventilation effect which caused then the pacemaker to pace at its upper rate limit. Another more serious issue can be if the patient is documented as having ventricular tachycardia. Today, electrode skin impedance measurements are used to measure respiratory rate in monitoring equipment. When you look at equipment, you can see that it gives you a figure for the respiratory rate. This is done through the electrodes with a very small current passed through the electrodes, and then the transthoracic impedance, or whatever we want to call it, measurements are used to measure respiratory rate. If one of the electrodes falls off, then the impedance goes to infinity and an alarm goes off in the monitoring equipment. But this is a case of a patient who was admitted to the emergency room with non-specific chest pains and was fully awake and alert, and they put the monitoring equipment on and saw this terrible ECG pattern, and therefore they did a 12-lead ECG as shown. This caused profound anxiety amongst the members of the emergency room staff, and attempted defibrillation was done even when the patient was awake and alert. After many shocks, unsuccessful of course, and many drugs, the patient was transferred to another hospital, the monitoring equipment was removed, and the heart rate went back to normal immediately. You can see there, though, there are small spikes here indicating that this is ventricular pacing at its maximum rate. The closed loop stimulation pacemaker by Biotronik in Germany, the rationale for this is that physical and emotional stress increases catecholamines. This increases ventricular contraction, and the sensor measures the changes in ventricular contraction using intracardiac impedance, not transthoracic, intracardiac. It does this by again passing small numbers of stimuli subthreshold, but this time into the QRS. There are 16 cycles of this low energy, and it goes for 250 milliseconds and starts 50 milliseconds after the stimulus artifact or the onset of the QRS. It therefore goes for 300 milliseconds. The impedance is measured between the cathode and the pulse generator can. Here is a typical closed loop stimulation artifact ECG. Very different from minute ventilation in that it only occurs during the QRS and T wave, again 50 milliseconds into the QRS, and stops before the baseline. The ECG returns to baseline. And there we have 50 milliseconds red highlight, and then 250 milliseconds yellow highlight. In this example, there is atrial pacing and ventricular sensing. This type of pacing system is very useful for vasovagal syncope, and therefore usually you do not see ventricular pacing. But here is an example of atrial fibrillation with ventricular pacing. And once again, we see the strange artifact, which is deliberate from the sensor and frequently attempts are made to redo the ECG, taking the patient to another room. And of course, this is very unsuccessful and therefore should be recognized as a CLS artifact. And again, because of the way the filters are generated into the ECG, you see lots of different patterns. But in every case, the artifact lies within the ECG QRS and starting after the onset of the stimulus artifact or the QRS. So what have we learned? Pacing in patients with chronotropic incompetence required to drive the atrium and ventricle in response to physiologic demand. The most common sensor is an accelerometer. The minute ventilation sensor uses changes in transthoracic impedance, which results in a continuous ECG artifact every 40 to 46 milliseconds. The closed loop stimulation sensor results in an ECG artifact 50 milliseconds after the onset of the sensed or paced QRS and continues for another 250 milliseconds. Thank you.